Recorded webcast introducing School-Based Health Alliance members to payment reform. John Leffler from John Snow Incorporated, also known as JSI, we are a healthcare consulting firm dedicated to medically disenfranchised people all over the world. Slides were developed by my colleague, Stacy Moody, who recently left JSI to rejoin her colleagues at the Colorado Association for School-Based Healthcare. So I'd like to thank Stacy for preparing these slides, and I'm happy to present them here in her stead. So cover 4 objectives: the payment reform landscape and how it impacts school-based healthcare. We'll identify what you can do in the context of payment reform, and by showing you some resources that can help you in efforts to engage. So what's driving payment reform in our country? According to Centers for Medicare and Medicaid Services, also known as CMS, in 2015, U.S. healthcare spending increased 5.8% to reach $3.2 trillion, or $9,990 per person. The overall share of the U.S. economy devoted to healthcare spending, 17.8% in 2015. This spending continues to grow at historical rates. It will reach 34% by 2040. Despite the health expenditures in the U.S., our nation has some of the worst healthcare outcomes compared to other high-income countries. We don't live as long as people in those countries, and we have more chronic diseases. The U.S. high healthcare spending and poor health outcomes have led to, in essence, a policy crisis. So state and federal stakeholders have been working to solve this. In this effort to change our healthcare system was the Affordable Care Act, or the ACA. The ACA had 3 key elements: improve access to health insurance, reform payment, and care. Now, it's still underway about changing the ACA, especially with regard to access to coverage. The other components, however, of the ACA have already kicked off changes in the healthcare system, especially regarding how care is paid for and provided. We're going to give you some examples of how the ACA and the subsequent legislation is allowing for innovation in care delivery and payment reform. Before we do, let's learn a little bit more about what we mean by payment reform or innovation. Reform is a strategy to change how healthcare is paid for in order to transform how healthcare is delivered. Efforts are geared toward what's called triple aim, and that's depicted in the triangle here on the right. This is a concept introduced by Don Berwick at the Institute for Healthcare Improvement to create a common understanding of how we want to improve value in healthcare. This includes 3 goals of better health for a community, patient experience, and lower costs of care. Better for a community means improving the health of populations, including prevention and health promotion, in addition to medical care, improving the patient experience of care, which means addressing patients' health in a manner that works well for the patient, and reducing the per capita cost of healthcare, so making it cost less per person. And so the 4th goal is added to the triple aim, which is reduce health disparities. Other times you'll also see a 4th aim referred to as provider satisfaction or joy in practice. But this aim is what is driving payment reform across our nation. So from a provider perspective, you might think about the triple aim in this way. These depict those 3 concepts of the triple aim. These 3 components resonate with the aims of school health centers stakeholders, including your staff, patients, and payers. So first, in achieving better care, are we interested in improving the way patients experience health by changing how healthcare is delivered? And in doing so, can that help practices attract and retain high-quality staff? Second, in achieving better health, would our benefit from practices having more flexibility to deliver high-quality care and to be integrating the currently fragmented components of the healthcare delivery system? This could be done by supporting communication, coordination between primary care providers and hospitals. And finally, would our community and indeed our country benefit from finding ways to be cost-effective and increase care access to preventive and primary care that will reduce the total cost of care? These questions that you can ask yourself. So, get to the triple aim with payment reform. Well, reform is changing how payment is made. So, what does that change? It's going to move from what we mostly have now, which is fee for service, and that's volume-based. That means it's for how many services were provided. So the more visits a provider bills for, more the provider eventually gets paid. So we're going from fee for service, that volume-based payment, to value-based payment. That's payment for how well the services met the same elements. So a provider can provide a good patient experience, reduce disparities, improve population health, all while optimizing costs, then they potentially get paid. So the idea is that payment reform, going to more value-based payment, facilitates practice transformation, which will support changes to how a provider delivers care to encourage quality improvement and patient-centered care. One example of moving from a volume-based care model toward a value-based care model is when a clinic integrates medical and behavioral health services for their patients. We are seeing more and more efforts to not only co-locate, but to also coordinate seamless care through integration. So imagine an adolescent who's at the clinic for chronic headaches. A medical provider there may also screen that adolescent for depression. If that screen is positive, then a mental health provider could come into the exam room and meet with that adolescent right then and there. So in some states, but not all, the Medicaid payment structure will not allow that clinic to bill for both the medical visit and the mental health visit that occurred on the same day at the clinic. So that volume-based Medicaid payment structure doesn't support this innovative care delivery model in this integrated care. Reform is an effort to allow more flexibility in how care is delivered so that there's more value in the care provided rather than a sole focus on volume. Reform should facilitate or support practice transformation and together move us closer to the triple aim. So if reform is moving from payments based on volume to payment based on value, how is value defined? The answer can be very complex. On this, we have a simplistic business equation for value. Value equals the outcome or quality divided by the cost. But how do you define quality? And how does the equation compute? One way that value is good quality for costs, but about great quality for medium cost, or excellent quality for high cost. So math equations aside, imagine you go to the grocery store and you're looking for paper towels. You see the long row of paper towel options and simply grab the cheapest ones without really looking at the description of absorbency because you use them that often and you need them for anything too major. So you don't really value how absorbent the paper towel is. You think about it. So me in my 20s, I wasn't really thinking about how absorbent my paper towels were. So fast forward to now, and I have two very active, somewhat absent-minded tweens. Seems like a day goes by without a spilled drink. My values about paper towels have changed. I didn't even know I had values about paper towels in my 20s, but now how absorbent a paper towel is really important because we need to ensure that those messes get cleaned up quickly before they take over the table and the floor. So now, as I shop for paper towels, I'm still looking at the price, but I'm also looking at the absorbency because I value that speedier mess cleanup, and I'm willing to pay a little more for it. Plus, I wonder if I end up using fewer towels in the end with the more absorbent paper towels. Okay, a little detour, but it gets really at the essence of how value is defined. It really is in the eye of the beholder. And with care, this means that the value is in the eye of the payer. So the payer as the consumer when they're paying for things out of pocket or through their health insurance premiums. You could have the payer as the health plan, like Medicare. The beholder is whomever is paying for all or even part of the health care. So I may decide that innovative services like sending a health coach to someone's home instead of bringing them to the clinic for a face-to-face visit with a provider lead to improved health outcomes of their beneficiaries. They value that, the outcomes, and the plan may be willing to pay for these innovative services like using health coaches. So to engage in payment reform, it's crucial that school health centers assess not only what they value in school-based health care, but also what their payers, likely Medicaid, managed care, or private insurance, value. So we've heard from many state Medicaid agencies that they view overall cost saving in the Medicaid program that shows positive health outcomes for Medicaid beneficiaries and reduce access to care. Does that sound familiar? Sounds like the delay. So what services does or can the school-based health center provide to their patients that overall lowers the state's Medicaid expenses, which you can demonstrate through data, positive health outcomes for patients, and limit access to care? This might be services related to chronic disease prevention and chronic disease management, including asthma, diabetes, or childhood obesity. To be successful with new payment models under payment reform, healthcare organizations must participate in care innovation. So one way to do this is for providers to look on how they can transform their operations to provide better care and produce better health at lower costs. This is referred to as practice transformation. So payment reforms support and enable practice transformation. And there are many different kinds of initiatives, some of which we'll talk about later. When you hear about practice transformation, just its overall focus is to shift from provider-focused care to patient-focused care. This involves using data to inform care decisions and sharing data among providers. It involves focusing on whole person care by integrating a variety of services like medical, behavioral, and social services into the model. It also involves improving cost efficiency and reducing fragmented care. All a few examples of how healthcare is transforming. Value payment is described as a broad spectrum of reform. This slide shows a framework for payment reform with 4 different categories. We adapted this framework into a simpler version. The full link to the version is available if you have the link at the bottom of the screen. This framework was developed by the Healthcare Payment Learning and Action Network, also referred to as the HCP-LAN. This is a group that anyone can join. You can go to their website and join this group. But this group was created to drive alignment in payment approaches to really be driven by public and private sectors of the U.S. healthcare system. Starting at the base of this slide is the fee-for-service with no link to quality or value. This is typically what you see now. The person is the payer for an encounter or service, and then the payer pays upon that service. So move to the next level, it's the same as fee-for-service, but there is a link to quality and value. So these are seen as payments for good performance that support reform, or paying for investments in infrastructure to support reform like health information technology. Secondly, from the top are alternative payment models built on quality and value. So here providers may have some shared savings, meaning if there are savings that are derived from the new payment model, the payer and the provider may share in that savings. This is called upside risk. Alternative payment model arrangements can also have downside risk, and that's when the potential loss for providers based on not good performance on quality or cost outcomes. And at the top is comprehensive population-based payment. These population-based payments or capitated payments encourage providers to deliver well-coordinated, high-quality, person-level care within a defined budget for a defined population. Population can be defined either before or after services are provided. And this model holds providers accountable for meeting quality and increasingly patient-centered care goals for a population of patients. Payments are intended to cover a wide range of preventive health maintenance, and health improvement services. And these payments will likely require care delivery systems to establish teams of health professionals to provide enhanced access and coordinated care. So as you move up the spectrum, as you see from that arrow on the left, the risk increases for the provider based on the type of payment model. But also, as you go up that arrow, the level of flexibility for how healthcare services are delivered also increases. And this can lead to an increased level of quality. So, to summarize, payment reform involves two shifts: more and increasing accountability for both quality and total cost of care, and a great focus on population health management as opposed to payment for just a number of specific services. At the beginning of the webinar, I noted that payment reform is one tool to achieve the triple aim. These discussed were increased access to care through coverage and innovations to change the way that care is delivered. So access to care was increased through Medicaid expansions, making health coverage more available through health insurance exchanges. Examples of how payment is changing through alternative payment models and accountable care organizations. Some states are also transforming payment through federal delivery system redesign improvement programs, referred to as DSRIP, DSRIP. We'll talk about these in more details on the next few slides. Across the nation, we're seeing innovations in how care is delivered through patient-centered medical homes. Innovations are also funded through CMS's Center for Medicare and Medicaid Innovations, known as CMI. A couple examples of that are the Accountable Health Communities funding or State Innovation Model grants. Let's talk a little bit about CMMI. CMI was established in the ACA, and the Innovation Center is tasked with testing innovative healthcare payment and service delivery models with the potential to improve the quality of care and reduce Medicare, Medicaid, and children's health insurance program expenditures. The ACA appropriated about $10 million to support Innovation Center activities, and those activities are initiated from fiscal year 2011 to 2019. So we said we are about SIM here, or State Innovation Model Initiative. The State Innovation Model Initiative supports states in transforming their healthcare payment and delivery systems. So to qualify for these awards, the states had proposed reforms that incorporated multiple payers and are expected to improve quality of care and the health of the state population while reducing costs. So that's triple aim again. Some states are receiving funding to support the testing of these models. Affiliates and school-based health centers should understand what innovations are occurring in their state or community and the potential impact they would have on school-based health centers. Innovations will impact school-based health center populations, as are focused on the aging population. Many do involve youth or entire Medicaid populations. For those innovations that are relevant to school-based health centers, it's really important to assess the impact of the innovation on school-based health centers. Could positively impact those innovations and how the school-based health centers can engage in them. It's also important to assess if the innovation could negatively impact school-based health centers. State affiliates and school-based health center medical sponsors, they also have more capacity to help school-based health centers engage in this level of policy discussion. So at the federal level, we've also seen the Centers for Disease Control and Prevention support work that intersects population health with payment reform through their 618 initiative. Through this work, the CDC is partnering with healthcare purchasers, payers, and providers improve health and control healthcare costs. CDC provides robust evidence about high-burden health conditions and actions that address these conditions, inform their partner decisions to have greatest impact on health and costs. 18 stands for 6 common and costly health conditions, and those are tobacco use, high pressure, healthcare-associated infections, asthma, unintended pregnancies, and diabetes. And along with the 6, you have 18, and the 18 stands for the 18 proven specific interventions that formed the starting point of discussions with purchasers, payers, and providers. So he's bringing together healthcare purchasers, payers, and providers with select CDC researchers, economists, and policy analysts to discuss ways to improve healthcare and control costs with the 18 interventions. 9 state Medicaid agency and public health department partnerships are already implementing 16 actions, including collecting baseline data and negotiating contracts with managed organizations. Through this initiative, CDC has a call to action for public health foundations, payers, and providers. Specific initiative encourages major payers and providers, which includes school-based health centers, to prioritize improvements toward these 6 conditions. Payers are encouraged to deliver the 18 interventions, and payers are asked to cover the 18 interventions. So the providers and payers are encouraged to monitor the outcomes of 618. School-based centers may be particularly primed to implement some of these strategies, especially those that improve access and adherence to asthma medication and devices, expand access to comprehensive tobacco cessation treatment, or implementing strategies from the National Diabetes Prevention Program. More information about the initiative is found on the website, including the 9 Medicaid agencies, and that work is already underway. So about patient-centered medical homes, which is their innovation. Patient-centered primary care collaborative defines the medical home as a model or philosophy of primary care that is patient-centered, comprehensive, team-based, coordinated, accessible, and focused on quality and safety. It has a widely accepted model for how primary care should be organized and delivered through a healthcare system. So, payment reform models are being used to support transformation to patient-centered medical homes. The Health Resources and Services Administration, or HRSA's Accreditation and Patient-Centered Medical Home Recognition Initiative is supporting health centers working for better care and lower costs for their patients. Supports health centers seeking to achieve ambulatory healthcare accreditation or patient-centered medical home, also known as PACE recognition. HRSA supports for training and TA, technical assistance, for recognition processes, and they might even help pay for certain recognition fees. Payers are also providing incentives to receive PCMA. These incentives could include monthly care management fees and a 4-month fee, in addition to fee-for-service payments or payments for certain types of visits. This Alliance has a comprehensive guide available on their website to help health centers in adopting key performance and quality improvement strategies that align with national and state-specific PCMs and standards. Walks through the benefits and the challenges of obtaining PCMH recognition. The link to ours is at the slide here. Accountable care organizations. Organization has been broadly defined as a group of shared accountability for the cost and quality of care delivered to a population of patients. ACOs tackle 3 core areas: implementing a value-based payment structure, measuring quality improvement, collecting and analyzing data. Both Medicare and commercial payers have embraced ACOs with somewhat promising results. The ACO program and growth in the ACO program under Medicare continues, with over 400 ACOs serving over 14% of the Medicare population. And there's similar interest in the commercial sector. State programs are also using ACO structures in 9 states currently, and 13 states are pursuing Medicaid ACOs. As the other payment reform opportunities, school-based health centers and state affiliates should advocate for ACOs to incorporate school-based health centers into their models. Involved, school-based health centers will then need to access reliable and timely data to monitor the specific indicators that the ACO is tracking to demonstrate their effectiveness and how they're delivering quality care with positive outcomes to the school-based health center patient population. In many cases, the school-based health center who can demonstrate this value to the ACO may receive enhanced payments. With our innovations, as more groups are taking financial risk for Medicaid populations, they're realizing that whole person care or better integration of behavioral health, medical care, and social services are needed in order to meet the triple aim in Medicaid. The National Quality Forum recently concluded that social determinants of health, such as education, context, income stability, food security, should be accounted for in payment rates and quality measures in many circumstances. The National Quality Forum made a call to the field to say that they want to hear more and see more experimentation. This idea of adjusting for social determinants of health. States are working in this direction. For example, oral centers are determining how they could adjust for social determinants of health in their alternative payment methodology. Centers can begin to track and assess their patients, or possibly the entire school population through school-wide screenings, but think food insecurity and homelessness. Some electronic health record systems already have a social determinants of health data collection tool that can be used. And also, there's a newer tool called Prepare, which was developed by a partnership of safety net providers to help providers track and assess social determinants of health. We're going to talk more about Prepare on the next slide, which is that once school-based centers have begun to document the social determinants of a patient or student population, this information can be used number one, it can be used to assess the student's needs and to direct implementation of programming to address those needs, and to demonstrate to payers the value that the school-based health center brings in payment reform initiatives. Reform opens the door for flexibility in reducing or investing in services that impact upstream factors that influence health. One example is in Oregon, where a regional Medicaid accountable care organization hired community health workers to help link pregnant or parenting teens to health services, and also address other needs such as housing, food, and income needs. We'll talk about Prepare. Recognizing the needs to treat patients with social determinants of health, NAC, the National Association for Community Health Centers, as well as the Association of Asian Pacific Community Health Organizations, American Primary Care Association, and the Institute for Alternative Futures, along with a group of pioneer health centers and health center networks in Hawaii, Iowa, New York, and Oregon, developed this tool called Prepare, and it stands for Protocol for Responding to and Assessing Patients' Assets, Risks, and Experiences. Prepare is an effort to help health centers and other providers collect the data that they need to better understand and act on social determinants of health, recognizing that providers are increasingly accountable for reaching population health goals, reducing costs. As we're talking about, it's key that providers and decision makers have tools and strategies to understand those upstream socioeconomic drivers of poor outcomes and high costs. Prepare is a tool that allows health centers and other providers to define and document the complexity of their patients, transform the way care is delivered, and demonstrate the value that they bring to patients, communities, and payers. School-based health centers are impacted by payment reform. They have opportunity to participate in payment reform in multiple ways. First, as Medicaid programs implement changes, school-based centers that bill Medicaid for services provided to their patients could be impacted. One example are the states that use accountable care organization models to promote delivery system transformation and payment reform. Many school-based centers engaged in care coordination and also using data to demonstrate quality health outcomes for their patients. For example, in Colorado, some school-based health centers that qualify as PCHs or care medical providers, PCMPs, receive an additional per member per month payment for each Medicaid beneficiary participating in the state's Accountable Care Collaborative Program that the school-based health center serves as the medical home. School-based health centers that are PCMPs are able to earn additional payments based on their region's performance in meeting certain quality metrics that they refer to as key performance indicators, or KPIs. School-based health centers sponsored by a federally qualified health center. There is health center-specific payment reform opportunity. Most health centers are paid by Medicaid through the Medicaid Prospective Payment System, also known as PPS. Under PPS, health centers receive a set payment for primary and preventive care services delivered during each patient visit. PPS was created to ensure predictability and stability for health centers while ensuring that the federal 330 grant dollars are dedicated to care for patients without health insurance, as intended by Congress. Instead of PPS, states might work with health centers to develop a Medicaid alternative payment methodology, also called APM, but often referred to as health center APMs or FQHC APMs, as those payments are not less than what they would have gotten under PPS. Health have to agree to the APM, and states can't force health centers to participate. FQHC APMs allow for increased flexibility in how care is delivered by a health center based on specific needs of the patients and community that they serve, including the use of integrated care teams and types of visits. 23 states that pay health centers via a health center APM. Some of those states, the APM is similar to PPS, but with technical differences. In other words, they may have a capitated health center APM, meaning they get an amount for each enrolled person assigned to them for a period of time. A number of states are using the FQHC-specific flexibility to form the way that the health centers are paid to promote care transformation and payment reform, or has implemented payment reform for health centers. And California is piloting a health center APM, while other states are in the midst of developing their own ways of reforming payment for health centers. The National Association of Community Health Centers, also known as NAC, has a growing number of resources on health center APM and payment reform, including studies of the Oregon and California reforms. The link to resources is at the top of the slide. Finally, the effort is starting to change how school-based health centers are paid by Medicaid in Oregon. The Oregon School Alliance's School-Based Health Center Alternative Payment Innovation Project is a county multi-organizational effort to look at the unique needs of school-based health center care coordination, the effectiveness of the delivery of health services, how alternative payment models can address those needs. Over the last few years, the State Alliance, Portland, local care coordinating organizations, representatives formed a collaborative on alternative payment improvement plans. And this is a work group to begin foundational work on potential alternative payment methods for the school-based health center model. The work group is defining school-based health centers' unique model in terms of the services and supports that are generally not found in traditional clinics, both those that are billable and non-billable. The group also worked to better understand the school-based health center patient population in the context of the large Medicaid system. The goal is to have a clear sense of whether the current payment strategies for school-based health centers are successful and appropriate to the kind of care that school-based health centers provide, and also to pilot alternative payment strategies. More information on the project is available on the Oregon School-Based Health Alliance's webpage, which is green here. School-based centers offer an ideal avenue for reaching and serving youth in underserved communities and also helping to address health disparities. School health centers are responsive to the unique physical and mental health needs of children and adolescents. School centers offer a variety of clinical services, including primary care, behavioral health, health and prevention services. Health centers offer a unique environment for youth to access preventive services in a convenient and trusted environment. These are the types of preventive and primary care services that are encouraged in reform. Additionally, school-based health centers have access to the entire school population, especially for school-wide screenings and health education. So access to a relatively stable, defined population of youth who are in school for at least 1 year, but likely many more. This offers an ideal environment for population health activities supported by payment reform. The structure and function of school-based health centers provide an opportunity for patient-centered, cost-effective care that improves the health of a population, such as the community in the school, and this also supports efforts to achieve the triple aim. The mechanisms by which payment reform are built and measured offer some challenges that school-based health centers need to overcome in order to successfully engage in payment reform. First, access to timely and reliable data is essential to engage in payment reform. Data will inform a school-based health centers as well as the payers' understanding of the population to be served and the types of services needed. Data is also essential for demonstrating value, the critical component of a value-based care and value-based payment. So some school-based health centers might have limited or unreliable data, but effectively engage in payment reform, school-based health centers must secure timely and accurate data on the population that they serve and quality of the care that they provide. So this may include data on health outcomes, for example, reduced body mass indexes, or hospital-related asthma visits. Data is also essential to determine the type and amount of payment to request from the payer. And finally, data is necessary to monitor the outcomes of any transformations. Does the transformation improve the health outcome of the patient or population? Second, some payment reform models are linked to beneficiaries' medical home. Possible school-based health centers should invest time and resources to become a medical home, and in many cases, they may be able to obtain patient-centered medical home or PCMH recognition. School-based health centers that are not considered the patient's primary care provider or medical home might be excluded from some payment reform models. School centers have to be aware of and engaged in the design of the models. Make sure that their services, all the strengths that they bring to achieving the triple aim, are acknowledged and addressed by any new payment mechanism. As mentioned earlier, school health center, medical sponsors, or state affiliates may have capacity to monitor and influence payment reform design. In fact, because payment reform is tied to payment from healthcare payers like Medicaid or private, school-based health centers that do not bill Medicaid or other payers are likely to be excluded from payment reform efforts. Helps you see some resources that can help you inform your efforts in payment reform. There's a growing number out there. Here are just some of the entities that have the most comprehensive, up-to-date resources. Some of them relate to federal, state policy, and advocacy resources. There's a growing field of knowledge out there for you to access. Here's another number of resources. The growing field of knowledge, academy, health, payment reform, and population health work. So we'd like to encourage you to get involved as as much as possible. I'd like to thank you for joining this webinar today. And this concludes our webinar.